All right, so I think we can get started. So good afternoon, morning, everyone, if it applies. My name is Lucia DG Turley. I'm the Senior Director of Editorial Strategy at CPE. Welcome to today's webinar, Care, Not Punishment, Equitable Responses to Mental Health Emergencies. For those of you joining us for the first time, the Center for Policing Equity is a nonprofit organization that is committed to empowering and supporting Black, Brown, and other vulnerable communities to redesign their public safety systems. We do this by providing decision makers with data, stories, and relationships that facilitate bold, innovative, and lasting change. So to just quickly go over our time together today, we're going to begin with some comments from our Senior Vice President of Policy and Community Engagement, Eric Cumberbatch. Then you're going to be hearing from a panel of experts about their experiences building, implementing, and advocating for alternative mental health response programs. We're going to wrap up with a Q&A session, so please do stick around. As the panel is going on, you feel free to put any questions that you may have in the chat box, and we will add them to the queue. So with that, I would like to introduce Eric Cumberbatch, CPE's Senior Vice President of Community Engagement and Policy, to give a couple of words to frame today's discussion. Eric, take it away.
Thank you. Good afternoon, and thank you all for joining our Care Not Punishment webinar. This webinar is part of our Public Safety Redesign series, which features a number of white papers on pertinent topics to police alternatives, or more boldly put, liberation from oppressive systems that overwhelmingly continue to fail Black, Brown, and vulnerable people across the United States. Whether we point to my home city, New York, in which Raul de la Cruz was met by police with weapons of war to respond to a mental health crisis, or as far away as California, in which Anthony Lowe, a double amputee, was shot 11 times and died as a result from his wounds as he was experiencing a mental health crisis. These stories are not anomalies, but are the reality of a network of system actors that prioritize and prescribe punitive measures to public health issues. As always, our webinars, white papers, and products are calls to action. They are tools for all of us to collectively actualize the change that people have been calling for over generations and still today. The fight for equity is now. With attempts to erase Blackness from history, censor women's rights, restrict access to voting, expel elected officials for doing their jobs while Black, and placing police officers in scenarios that only exacerbate the risk for injury, incarceration, and death is demonstrable. I'll conclude this opening with a reference from a chapter from a book that my father gave me when I was 13, and for some reason, he thought I was a man at that age and required me to spend my summer reading Seize the Time by Bobby Seale. And the last chapter of that book is Seizing the Time, in the fight for revolutionary change. And this is the time, and we are the cavalry to spark that revolutionary change. In solidarity, I thank you all, and it's my pleasure to introduce Charlotte Reesing to jumpstart this panel discussion. Peace.
Thanks, Eric. And thank you to everyone who is in attendance. We have a wonderful panel here today. I'm going to do a brief intro for each of them and then let them talk a little bit about what brought them to this work. So Lupe Washington is the Division Director of Community Health and Violence Prevention in Harris County, Texas. Sharon Scully is the Director of Justice Policy Initiatives at NAMI's National Office. And Larry Jefferson Jr. is the Director of the State Office of Public Defense for the state of Washington. I'll start with Lupe, if you can just talk a little bit about what brought you to this work and why this work is important to you.
Sure. Thank you so much for having me today. What brought me to this work is that I spent over 24 years as a juvenile justice practitioner. And when I saw the posting for this brand new division that was getting started in Harris County, it just seemed to align with, all the beliefs that I've had and the approach that I was taking in my career as a juvenile justice manager, asking all the whys. At the time, I just didn't realize it was considered a public health approach to violence prevention. And after reading the job description for my current role, I was just really fascinated, and being able to come back to Harris County after having been gone for about 7 years, being the assistant chief in a different county, it just seemed to align with my approach and, how I just really value the importance of looking at the social determinants, that are going on in people's lives. And so it was just a great fit. I was fortunate enough to be hired. So I am the first division director for this division in Harris County. So we're fairly new. I started in December of 2021 and was able to start 3 different programs last year in the division. When I was hired, I was told I had 3 months to start, and we got it done. And the first one was the HEART program, which we're going to talk a little bit about later. So again, thank you so much for having me.
Thanks, Lupe. Shannon, do you mind going next?
Yeah, thanks so much, Charlotte and Eric, for your opening comments. I'm really excited to kind of be in this space to have this conversation. And as Charlotte mentioned, I'm with NAMI, or the National Alliance on Mental Illness. We are the nation's largest grassroots mental health organization representing people with mental health conditions and their family members. And I mean, there's what personally brings me to this work. I've spent a number of years working in relationship to the justice system, and just knowing that it does not meet people's expectations. The services we provide are not meeting the expectations of what people think that they're getting when they connect with the criminal legal system here in America, or when they reach out for services, especially for mental health services. And the criminalization and lack of community health services is what really has spurred a lot of the NAMI movement over the years. We started off as family members around kitchen tables having conversations about how do we get our loved ones who have serious mental health conditions, people with schizophrenia, people with bipolar disorder, because what parents were being told at the time was that this was a result of your parenting. Your child was ill because you did something as a parent that inherently, caused them to behave in the way that they were. And that really is where our movement started. And I think we're always, we are always at the table wanting to have conversations about how do we ensure that people are connected to the care that they need. No matter who you are or what you look like or where you are, how do we get you connected to that care and get you connected to the services that you need? So excited to be here and to be talking more about this.
Thanks so much, Shannon. And last, but definitely not least, Larry.
My name's Larry Jefferson. I'm the Director of Public Defense for the state of Washington. I've been an attorney for 28 years and I was a public defender for 25 years. And I guess what I'll tell you is when I got to court, what I wanted to do was to have Perry Mason moments in court and break down witnesses. And everybody would know that Larry Jefferson was the greatest orator in earth and won all the cases. What I found was that I can remember winning a case and then seeing my client like the next week thinking, well, what's going on here? I won your case. Everything should be solved. And basically, what I came to conclude is that if we weren't addressing root cause in court, then we weren't really doing anything at all. Those were really emphasized once I started to have a son who passed away because of an overdose. But about the 10 years before that, because of all the dysfunctions that we have in our society. And what I mean by dysfunction is we're on stolen land, right? That people's bodies were stolen and that people's labors has been stolen, and none of those things have been healed. So that basically we've got trauma, and if it's not transformed, it's being transmitted. And that's what's been happening. That's what happened to my son. That's what's been happening to me. And that's what's been happening to all my clients, is that depending on what zip code you're born in, it depends on how much help that you receive. Also, what I found was the more that I worked with organizations like NAMI, the more that I was able to work like directly with police officers and social workers and peer support, the more that I could provide a team around my client, then we could actually win. And it might not mean winning the case. And actually, the case really didn't matter. The case was just a symptom. And so I'm really happy to be here today, because what I want to do is give power, not to the government, but power to people to resolve their own issues, but also to get the help that they need. Thanks.
Thanks, Larry. And to get us started, I am going to list off, and I'm sorry to list off stats at people, but it'll be quick. Some of the findings from our report, and then I'll get into questions with the panelists. So systematic inequalities make Black people and other groups significantly more at risk of police contact and mental health emergency response and its associated harms. And in terms of mental health treatment, there are massive inequalities. So Black patients are much less likely than white people to have mental health care access or receive guideline consistent care. Black people are regularly overdiagnosed with certain psychiatric conditions like schizophrenia and underdiagnosed with mood disorders. And Latinx, LGBTQ, and unhoused people experience well-documented disparities in access to mental health care and disparities in police contacts. So to the group, as I'm sure the panel is aware, people with serious mental illness are much more likely to experience use of force by police than others. They make up 21% of people killed by police since 2015. And we've also found in our research that police view people with mental illness as particularly dangerous. Can you talk a little bit about the risks of having police respond to mental health emergencies? And any of you can jump in.
We're all trying to be polite, but Lupe, why don't you go first?
Thank you. Yeah, so our HEART program, which stands for the Holistic Assistance Response Team, it was formed so that we could respond to nonviolent 911 calls that go through our Sheriff's Office Dispatch Center. And the goal for our entire division is to prevent the criminalization or over criminalization of individuals, who have social service needs. And so we know that when law enforcement responds to calls of individuals who are unhoused or people having a mental health crisis, a lot of times it's going to escalate and not end up well. And these individuals will end up incarcerated and then go through this legal system and, go through kind of a revolving door. And so our aim through our HEART program is really to dispatch non-law enforcement first responders. These are individuals, it's teams of two. You have a crisis intervention specialist and a certified EMT who go out and respond to these nonviolent calls. And so they go out, provide on-site crisis intervention, de-escalate whatever situations are happening, and more importantly, connect these individuals to the resources that they need. So we're really big throughout our public health department, and we're real careful not to use the word referrals. We like to use the word connections or linkages. And so our HEART folks are actually linking these individuals to the crisis intervention, counseling, grief counseling, whether it's assistance for housing, food. We're actually making sure and we're verifying that they're getting the needed services so that they're not having to call, for law enforcement or get law enforcement involved. And hopefully we can stop the 911 calls and free up our law enforcement partners to go out and respond to the more violent calls that are happening. So I think, what we're trying to do is really eliminate that contact, that initial contact, so that we're getting them the correct services, the right people coming and helping them. If there is a need for additional services, they do get a 24-hour call after the initial contact to ensure that they've made the necessary connections. If need be, the caseworkers go out in person to these individuals at their homes to make sure, to help them. A lot of people don't know how to use their phone. Everything's online now. Many of them may not even have an ID or the needed documents to even enroll in the services that they need. So these caseworkers are going out to actually physically help them navigate these systems.
Okay.
I can also jump in here. What Lupe kind of describes is something that we're starting to see as a growing model in a lot of communities across the country. For a number of years, I think that there have been a lot of programs, trying to get started. And, it was the unfortunate murder of George Floyd that I think was really kind of something that really kind of stimulated a lot of movement for other communities to really pick up a model that has been around for a very long time. And what we've been seeing, the challenge of finding an alternative is that law enforcement is available 24 hours a day, 7 days a week, 365 days a year. There is no other social service that is available like that. And there is nothing that we invest in that is available to that extent. And the reality is that mental health crisis happens 24 hours a day, 7 days a week, 365 days a year. And so we're really looking right now at, how do we build up services that people need to make them available when people need them, and really start looking at how do we untangle, this system that we have created where law enforcement is the primary first responder. And, some of the challenges in having them go out that, I hear from countless families is one, often, especially for people who may have paranoia or delusions as part of their mental health symptoms that are happening during a crisis. Part of having a government official or someone in a uniform go out and really confront you, just again, as Lupe mentioned, really makes that escalate. And we hear this as kind of a consistent theme throughout stories that we constantly hear from folks. The other thing that I think, creates as a challenge is that, law enforcement isn't necessarily trained to respond to someone in crisis, right? We can give them skill sets to de-escalate someone, and we can give them skill sets to try to.
Oh, I think we've lost Shannon. Larry, do you want to jump in until we get her back?
Yeah, well, where I really resonate with Shannon is that we need to create an infrastructure. And by that, what I mean is I want to create an infrastructure in our communities, led by our communities, led by our trusted partners, meaning that that we need to sort of model these things, because mental health isn't something separate between me and other people. I have mental health issues, right? I'm a human being. I'm still in the same zeitgeist as everyone else. So I need to learn skills, how to take care of myself and my own mental health needs. And where I've been able to partner with NAMI is great about teaching folks and families different skills, especially skills that say this is not your fault, right? This is not your fault. This is what's happening. And we have to create infrastructure using, I don't know, our synagogues, our churches, our boys and girls clubs, anything else other than having to deal with the police. And this, again, is, I do counseling 3 or 4 times a week to deal with. I just lost my son. And, after going through 10 years of hardship, lots of NAMI classes, things of that nature. And so in order to be a director, I got to have my game on in order to do that. But what my suggestion is that we all need to participate in this process. We are in a democracy, and the more that citizens participate, the more that we can help folks that are actually suffering. I'm not a big fan of medications, but medications can be very helpful to certain individuals. I think talk therapy can be very helpful, but ways that people can partner with other mental health agencies is volunteer an hour. Just listen to somebody an hour. Imagine if we have someone who's going to talk 24 hours a day, that's 24 volunteers. So it's taking steps like that I think can get us involved in our communities so that we can actually see what's going on, participate ourselves, in order to resolve some of these things, because if we don't do this participation, people that look like me are going to be killed. There's not a lot of places where a Black man can go around and be angry, or anybody can go about and be angry. And we have plenty to be angry about. You got housing discrimination, you got job discrimination, you got education discrimination. You got that your ancestors were stolen. You know, I happen to know where my grandmother was born in 1877, which is a great year, but it's also a year that the North left the South. And with that, domestic terrorism started that has not finished. You know, to me, just going outside is a revolutionary act, you know? So to think that people aren't going to have mental health issues when for our, you know, just thinking about guns right now, guns is a leading cause of death for children. But for Black people, it's been the leading cause for children since 2006. So thinking all of that, people are already boiling by the time officers show up. And then officers, because of their history and where they came from, you know, historically being slave catchers and being controllers, we need a different mentality of individuals to be talking with folks that are harming. So we really got to go forward with talking about trauma. And trauma isn't saying poo-poo to people and saying, oh, you got a little boo-boo. It's really listening to people about what's going on and providing the basis for them to be able to express themselves. Thanks.
Thanks, Larry. And Shannon, we lost you in the middle of your answer. Do you want to jump back in, or we can move on? But
we can move on to the next. I think I'm connected now. Sorry, everyone.
Okay, no problem. It happens. So the next question is for Lupe, and we've been getting a lot of questions in the chat with a lot more specifics about HEART. Can you talk a little bit about how the program got stood up, how community was involved, kind of just how you made some of those baseline choices, funding, those types of things?
Yes, absolutely. So again, going back to the murder of George Floyd, you know, that kind of just prompted a lot here in Harris County as far as the movement, and our commissioners court actually came together and allocated, you know, funding for these programs and for the division that I'm over to get started. And so they allocated, we are completely funded with general funds. So we're not funded with grant funding. And that was based on our commissioners court. You know, they decided there was a need to do violence prevention, to address these types of calls. Now, Harris County is a large county. You know, there are 4.7 million people in Harris County. And so we started out, you know, it's a pilot program and it's still in its pilot phase. The area was selected. We are in partnership with our Harris County Sheriff's Department. And so our sheriff is 100% on board with the programming. And we have a program manager at the sheriff's office that works specifically with our HEART program as well. And so the calls come through their 911 dispatch center. We have also added the non-emergency hotline where individuals can call in through that number as well and request HEART directly. The area was selected. It's the northern part of Harris County because it was the area that had the highest volume of nonviolent calls at the time. It encompasses 148 square miles, which is, you know, the area that we're currently in. It does also happen to include one of the areas with the highest rates of gun violence. But again, overall, it was selected because that district, the sheriff's office district, it's District 1, because it had the highest volume of nonviolent calls when we were starting the program up. And that's where we decided to go first. Our goal for year one was 750 calls that HEART would respond to. At the end of year one, March 21st of this year, that was the end of year one, the teams had responded to over 2,000 calls.
Amazing. Thanks, Lupe. Shannon, so these programs are being stood up all across the country. Can you give us a little background on what the landscape looks like across the country and a little bit about how different some of these programs are?
Yeah, absolutely. And I will point out that, you know, up until I think a few years ago, and I'll talk about what kind of stimulated some of that, again, this was very, very localized. So a lot of you have probably read or heard about the CAHOOTS model, which has been operating for a number of years. There's the CIT model, which is really a community collaborative that involves law enforcement. In the early 2000s, the federal government passed MIOCRA, the Mentally Ill Offenders Treatment. I always have to spell this out for myself, but is the Mentally Ill Offenders Treatment and Crime Reduction Act, which included a program called the Police Mental Health Collaboration Program. So there's a lot of, NAMI was partnered with the National Association of Counties on a program called Stepping Up, which was about the reduction of people with mental illness in jails. And so there's been a lot of these programs where I think people have been creating models around how do we respond to people in crisis? Because what we find is that, when we really kind of dig down into the data, a lot of the people that end up in jails are there for very low level crimes. They're often there for what we at NAMI refer to as nuisance crimes, right? So things like sleeping in public, making noises, peeing in public, things like that. Things that often are just really related to things like symptoms, being unhoused, a variety of other things. But being in jail is not going to solve that. And so there have been a number of these models, but then as I referenced, we really saw a pick up in this because a couple of things happened at the same time. There was the murder of George Floyd, and Congress passed the 988 Implementation Act, or the 988 Designation Act, which basically designated 988 as a national 3-digit number to respond, to call if you were in a mental health crisis. And so, yes, there's a lot of things about, 988 was implemented officially last summer. There's a lot of questions and different understandings about what 988 is. And so I kind of share at the very simplest piece is that it is a 3-digit number to provide support over the phone. It replaces the National Suicide Hotline, and it expands to also respond to other types of mental health crisis, whether it's related to substance use or whether it's related to psychosis. The intent is that it is there for more than just this. And so in addition, in this piece of legislation, what was there is Congress opened it up so states could pass and they could levy fees against their cell phone bills in their states, similar to how we pay for 911. So if you go and look at your cell phone bill right now, if you're in the state of Washington, you're probably going to see a 988 fee because they passed one last year. If you look at your cell phone bill, you're going to see that there's a 911 fee. And that's how we pay for 911 services. And so Congress essentially passed, in the 988 Designation Act, allowed for states to do this similarly, but for 988 and crisis services. Additionally, there's been a lot of focus on the need for mental health resources. And so I think this kind of all came to a head. And so there's been a lot of money that has been, given to the states in order to put into place crisis services. And the model that, NAMI often advocates for, and we are working to support kind of being created, across, in communities across the country, is something that the Substance Use and Mental Health Services Administration, it's a model that they put together and kind of published guidance on a number of years ago, which kind of calls for 3 types of services to be kind of put in place. And that is, 24/7 call center hotlines, mobile crisis teams, and something we call crisis receiving centers, which is an alternative to emergency room, taking people to emergency rooms, essentially. And so, because of all of this kind of coming and kind of happening at the same time, we've seen a lot of communities kind of taking advantage of the resources that are out there, that include, the resources that are out there that they can use to kind of create alternative options, because that's really what this is. This isn't about the community necessarily sending out someone besides law enforcement. This is giving your community different options, different ways to reach out for help when they need it. Because what we really advocate for is when you're putting these crisis services into place, Don't make someone have to go through an emergency hotline in order to get a mobile crisis team. Don't make someone go through a mobile crisis team or a law enforcement officer in order to be able to go to a crisis stabilization or crisis receiving center. Let's create options for our community members to make decisions about what they need in that moment and how to leverage that. A resource, and I think Charlotte dropped this into the chat for folks. We operate a website called reimaginecrisis.org. If you are interested in learning more about what is kind of happening in your state around legislation and crisis response services, we do track that in live time. And so we are currently in the middle of state legislative sessions. And so that is very active. And we have a number of other resources on that website where you can check out what's going on.
And Charlotte, if I can just give sort of personal experience. Here in Olympia, Washington, they had looked at the Eugene Cahoots method. And so in 2017, there was a levy passed in the city that I'm in that formed this program. And basically what the program did is it hired folks who had lived experience, meaning folks that had been incarcerated before, and those types of things. And what they did with the police were identify target population of who was in downtown Olympia, the 20 highest users of public services. It just so happened that my son happened to be one of the highest users of those services, meaning getting a lot of phone calls, a lot of interactions, going in and out of the local hospital, for mental health treatment, for substance abuse treatment. And so what this did is it made that there were these two folks that were out there. And one day I got a text message, and the text message said, "What kind of food does your son like? You know, what kind of snacks?" And I'm like, "Fishy crackers." And so they start giving my son fishy crackers. This is on the street. And so he's not very receptive and not willing, wanting to do anything, but they kept contacting him. And then after he was arrested and then released, the first people that he contacted were these crisis response folks for, "Hey, what can I do?" And so what that turned into is sometimes he would call them and say, "I need a room for a couple of nights." And then after he got a room for a couple of nights, they said, "Well, what do you want to change about your life, or what do you want to do?" And they eventually said, "Hey, I would like to go to substance abuse treatment, and I'd like to talk to my dad." So what that means is that I now had a team that was sponsored by the city, and the police were taking my son to treatment. Once he went to treatment, then I could interact with him as a dad. Once I could interact with the dad, then I could bring in mom. Then when I could bring in mom, we could go, "Well, what do we need to do?" Then we hooked up with NAMI here in our local community to then give us information about how to interact. And so it just created a beautiful partnership. And those are the types of partnerships that we need to provide within our community. We've gone on to enhance our services here. We've got something called Arrest and Jail Alternatives. And they use case managers and mental health professionals to go out and meet people before something happens. So, because police are great at identifying, hey, something's up, and they can identify the people who are doing it. And so what we're doing is we're establishing relationships for folks where every other situation had failed them. School failed my son, mental health centers failed my son, everything failed them, but not this program. And this program allowed us to have, once the pandemic started, the best 6 months our family had in the last 10 years. And so when you have that sort of experience, you then gain confidence in the local infrastructure around you, and you're able as a family to build from there. And so those are the types of structures I think that we need. As a defense counsel, when I found out that my certain clients had that team of mental health professionals, then you can have them, I'm a lawyer, so I want that team to show up at court and say, "Hey, Your Honor, let so-and-so out of jail because they're going to be working on all this stuff. And if you just put them in jail, they can't work on the things you want them to work on. which would be not preventing a crime. So to me, this all has a real important synergy. And I think more attorneys should be taking advantage of these programs to help build teams around their clients to actually get them to address root causes. Thanks.
Thanks, Larry. I really appreciate having your personal take on all of this. It really grounds the conversation and makes it much more than just a wonky policy conversation, which these tend to be. So I do really appreciate that. I have one final question for the panelists, then we're going to jump to Q&A. Our Q&A is blown up. So my final question is that a lot of concerns have been raised around recreating or replicating some of the inequities we see in policing in mental health services and social service systems. If any of you can just talk a little about if you have experience with that, if you're seeing any risk mitigation that seems to be effective, and just making sure that we're not perpetuating different harms in different systems.
I'm going to go first before these learned individuals say something. But so I think, you know, I went to a local prison, and on the wall of the prison was people from the armed services. So the people that the prison was attracting to be able to guard these people were from the armed services. And that was the wrong types of folks, in my humble opinion, to be with folks who needed healing. And so we really need to start with a conversation of why we're here, what is the purpose of our organization, why are we doing this, and what is a common, what is the best evidence, what's a trauma-informed approach, and we need to take into account issues of equity, meaning who are the populations that have been harmed. And so right now, what I find is that in most police organizations, they're not really able to freely have that conversation, or half the department has that conversation, but the other half is still welded to these things. And so for me, the more that we can grow outside of our traditional all in the police, the better off we're going to be with new organizations that don't have the baggage of the past, but have the promise of the future. Thanks.
And I can just, jump onto something that Larry, Larry really kind of set that up nicely. I will point out that while we are, and a lot of people around the country are furiously, advocating for the increase in mental health services as an alternative to a police response, this is a tiny, tiny little piece of what is happening in the larger mental health conversation going on in this country right now. And I would encourage you that if you are leaning into the piece on policing and alternatives to policing, also lean in on what are the reforms being made to the mental health system in your community. The reason Black and brown people receive mental health services at a much lower rate than white people is that I often say that like a lot of medical things in this country, it was created for white people. And so I think, there's been a little bit of a reckoning that has slowly been growing kind of in the mental health space around, we need to be recruiting and retaining people that look like our communities so that they can serve people in our communities. We need to be thinking about all the different types of providers that we need. There's a ton of work that has to be done on the mental health system side, and shifting emergency response and crisis response from the criminal justice system over to the mental health system is not immediately going to change any of that. But I think it provides us with an opportunity to really dig in and look at who people are, what harms communities have experienced at the hands of, not only the criminal justice system, but the mental health system, and how do we start remedying that as part of our process for changing what this system looks like. Because what we're doing is we're really have an opportunity. There may be models out there, they may be solutions and policy solutions that we are raising, but we are creating new systems right now. We're creating a new way, a new resource for our communities. And I think we have this opportunity, especially with a lot of the conversations happening around identity and intersectionality and how that impacts the way we interface with systems and the community and the people around us, applying that and thinking about that really critically as we're creating these systems is going to be just as important as we think about how do we sustainably fund this? How do we make sure we have the resources in place and the sustainability for this? How do we make sure we really appropriately untangle this so that no matter what the situation is, no matter who is responding, everybody, gets what they need at the end of the day. And so I think, thinking some of those structural, like thinking about some of those issues is just as important as kind of all these other pieces. And I'd really challenge you to lean in and ask some of those questions, because I think inherently transitioning from one system to another is not going to solve, a lot of the problems that we're looking at. I think it's going to solve a piece.
I want to add on to that. First, I want to let everybody know that the HEART program is just one of a few programs that our Sheriff's Department is using, to address mental health issues and mental health calls. They also have a program that's called CERT, the Crisis Intervention and Response Team. And so you have a deputy who goes out with a master's level clinician, and then they have a clinician officer remote evaluation program, CORE, where they do it remotely via an iPad, in some instances. So we're just one of a few programs in the county. And then the city of Houston's police department has their own MCOT program that is similar for mental health calls. But I wanted to touch on the community. We've been very strategic as we developed our division to have a very robust community engagement. Like Shannon was saying, we want the people serving and out there and working with the individuals to look like the communities that we're representing, and so in my violence interruption programs, I hire credible messengers from the community that we're serving, and we're being very strategic with our HEART program as well. And we have a lot of people who are very, very interested in the HEART program, since before the program even launched. And so we have a racial and ethnic equity committee, the RE committee here in the county, that has been very involved with us from the beginning. And, they make sure that they're following up with us. How is it going? What are the teams looking like? Are the people speaking the language of the community that you're serving? And as we are looking to expand to another district, it's not just Spanish that we need. We also need people who speak Vietnamese and other languages here in Harris County. So that community engagement has been vital. And we continue that robust community engagement now. My team averages 20 to 30 events a month. So we go wherever they want to hear from us, whoever is interested in our programs, because we do want to let people know that we're out there, and we're still hiring individuals, from these communities. Those are the people that we want working with us. And so I just wanted to let everybody know that community engagement piece is vital to any program that's going to happen. You want to go out there first and let them know, this is what we're thinking about doing. What do y'all think? Because their feedback actually helped us really as we evolved, like, oh, okay, you can't come here and call us, Sunnyside and we're South Park, and y'all need to understand that we've been doing this for a while. And those partnerships have been vital. And so now we have churches that partner with us. A church in the HEART area, one pastor gives us 25 to 30 of those care kits a week to hand out to our unhoused individuals that the HEART teams are serving. And so that community engagement and partnering with community-based agencies has proven to be vital for the work that we're doing out there and the communication of the work and to continue. So now, we have some individuals who just know the HEART people by name, and the teams know them by name. A lot of them are unhoused, and so they know that they're there to help. And I tell my team throughout the whole division, our reputation is going to be built on the actual services that we actually connect people to. We're not making empty promises. We have to be out there and, follow through on what we say we're going to follow through on.
And I'll just add, we also need to change our views on punishment as well. And that what I mean by that is, if we think about our people that have gone to prison and those types of things, their life expectancy goes down and their families' life expectancies goes down. So when you're doing that, or when you're jailing someone, you're not just jailing them, you're jailing the whole family. Everybody has extra costs. And so what does accountability really mean? Accountability means being with your family. And so what we need to do is structure things so that victims always get services, that people are held accountable, and that we do so in ways that are safe and that are equitable. And also, just one last thing, we need to support our young people to avoid these types of myths. We need to give them the skills so that, some of these things you can work with peers on. You don't always need a social worker or a clinical psychologist in order to talk about how you're feeling today, what's going on for you, and what are the things that you need to do to keep yourself sane, and to be able to deal with all the traumas that we have. So that individual work needs to take place in our schools, and giving our folks that sort of language necessary so that we don't have to use the HEART program all the time. These are things that we can do ourselves. We don't need the government for everything. We just need them to do some stuff, right? All right.
Thank you all so much. So we'll move on to Q&A. I am not going to be able to get to everyone's questions. I will tell you that right now. So if you have additional questions, you just want to chat, you want to get in touch with one of the panelists, please feel free to send me an email. I am putting it in the chat right now. And I am going to group some of these questions together so we can touch as many as possible. And I also just want to flag that there were a lot of questions about police training. And because we don't have anyone on the panel that really works directly with that, I'll direct you all to that section of our report, which we will share out. And we have a whole section on sort of like harm reduction measures. If there aren't alternative crisis response, what can communities and what can police departments do to ensure the least harm possible when they do respond to mental health emergencies, which they will continue to respond to mental health emergencies regardless of whether or not we institute these alternative programs. Okay, so we got a lot of questions about how to respond to pushback against alternative response. Like how can we push legislators? What have been successful arguments? Is there things we can hold up as examples that would be helpful for community members that want to push legislators to make these programs happen in their communities?
Number one is cost effective. But in order to be cost effective, sometimes these things takes time. When you move a person who is huddled in a doorway, right, and over an 18-month period of time, they're now housed in an apartment, you have done an incredible job for public safety, because now those officers who are responding to that person every day, they're not doing that anymore. And when those officers see a person that they thought, there's no way that person's changing, they're going to be that way the whole time, when they actually see that happen a couple of times, it completely changes that officer to know, if I provide these services on a consistent basis, I am going to catch a few. And I don't mean catch a few by sending them to prison. I'm going to catch a few, meaning adding them the services. There's nothing better than I've seen is being on the street and walking with the officers and seeing people smile, seeing people swear at the officers, but in a friendly way, and say things like, "Thank you for helping fix my teeth." Those types of interactions. And so these things build on each other. They seem expensive at first, but the cost effectiveness of having a team around a person who's in jail, there's nothing more effective than when I went with an officer, a social worker, to one of our local mental health facilities, and I said, you need to keep this person in here one more day so that we can convince them to use their correct name so they can get Medicare. The person wouldn't use their name because they had trauma around it. So we just needed another day. And so when you get those kind of partnerships, those are when you're relationships last a lifetime. Transactions don't. Thanks.
Yeah, Charlotte, I'll just jump in on a couple of things. So I would say, first of all, at this moment, the amount of federal dollars that are available to start setting up these programs is at a an amount that you're just never going to see again. So a few things that I would point folks to. The American Rescue Plan, dollars that are already in your states. There was specific guidance from the US Treasury that specifically highlighted that you could use these dollars to address the mental health crisis happening in our country, that the mental health needs of your community was part of the pandemic, and you can use these dollars towards that. And so that is state governments have these dollars. This is something that your legislature can be directing those dollars towards. Similarly, through the American Rescue Plan, there was an expanded, I'm going to get real wonky on you guys right now. There was an expanded FMAP through the Medicaid program. And basically what that means is for the next 5 years, your state can opt into provide services through Medicaid for mobile crisis care. This is available if you want to connect and reach out. Every state has a Medicaid director. They should know about this. A memo went out to all Medicaid directors, and this is available now. So they can opt in as a service that they can provide through the Medicaid program. And the federal government for the next 5 years is going to pay for the majority of this. So this is just going to barely cost your state anything. So those are kind of two really big things. Additionally, what I would say is that the fee that I mentioned on cell phone bills, a lot of people say that local and state government, tax base is strapped, that we no longer have a lot of flexibility in dollars there. This is a new source of funding. And what I will direct you to is on the Reimagine Crisis, our Reimagine Crisis page. NAMI has done a series of public opinion polls around 988 and crisis services. And one of the things that we found through there, through that public opinion poll, is that the public is overwhelmingly supportive of paying extra on their cell phone bill every month if it supports crisis care. That number went up when we went into the details about what that looked like, what types of services this might pay for. And so if you are doing advocacy, I encourage you to go to our Reimagine website. We have a lot of advocacy materials on there. Additionally, you can get that data specifically related to our public opinion polling, and we will be coming out with a third iteration of that late this spring, probably early summer. So you can definitely look through that. There's going to be a lot of advocacy resources around that.
I'll just add that I completely agree. We have to tie our results into the cost savings to the county, and to the public, and that I'm not gonna sit here and say, oh, everything's been peachy and we haven't had any pushback, because we do. And so what we're trying to do is just show our results, show the impact that we're making. We're not here to make it a political event. We're trying to just serve people. A perfect example, we're trying, in addition to not having our law enforcement officers respond to these calls that they shouldn't be responding to, we're trying to reduce the number of repeat callers to our 911 system and also our EMS partners. Perfect example, we had a 74-year-old woman a few weeks ago who, her home, she called 911 because her spouse was deceased. Law enforcement went. They had a difficult time finding the gentleman because they were hoarders. Their home was just in such bad shape. Nobody could tell from the outside what the condition of the home was on the inside. The lady really did not want assistance. It was really hard to get her, she was in such bad shape. The staff were trying to even get her food. Heart was called, in a similar situation, and it took them 2 hours to gain that lady's trust. She was in desperate need of medical attention. And then the very next day, our environmental public health supervisor went out with the Heart team. It took them 8 hours to talk this other lady into getting the needed medical treatment. When we looked at the number of calls that had come from her residents in 12 months, it was over 200 calls to 911. And since that time, we called and checked, and there have been 0 calls to 911 dispatch. And so those are the types of numbers that we're keeping. We're very data driven. Harris County is a data driven, performance based. It's a performance based county. and our budget depends on it, depends on the outcomes that we are putting together. We are the recipient of a Department of Justice grant, and we are using that money to help us with, adding to our mental health services that we're going to provide for our heart participants, but other participants in our division. So we're also having to do some, capacity building. We were finding, the pandemic exposed even further the lack of services and resources that our underserved populations actually, just the lack of services that they're providing, because nobody is out there providing the services for them, or the county hasn't kept up with the changing demographics in certain areas. So what we're trying to do is just keep our stats, show our numbers, and show that it's working. And then hopefully we can, continue to expand. And if there are any individuals who are doubting how the programs can be effective, we can show them the statistics and our performance evaluations, because we're doing that simultaneously as well.
Thanks, everyone. And I will also just flag that there are jurisdictions that, in addition to finding cost effectiveness and improved outcomes for folks, there are also places that have found decreases in crime, certain types of crime. So that's in the paper. You can look it up. We are running short on time. I'm going to ask one more quick question. We might go a little bit over, but I think we can be brief. So one of the things that was flagged in the question, I know this has been flagged a lot of places, is that some alternative crisis response programs are having staffing issues, maintaining staff, who to staff. Lupe, do you have any experience with that? And Shannon or Larry, have you seen any of that?
Initially, we contract with a vendor to do the heart program. They do all the hiring. Initially, at startup, it was difficult getting the right people in place. And I think leadership is also key for the program. So the turnover rate was pretty high in the first few months. But once the program got going and it was a little bit more established, and actually we had a new director come in, new director of operations, now that turnover rate has dropped significantly. So the staff are heavily trained when they come in. They're being told during the interview process the type of program that it is. But it helps when more and more of the general public is seeing the vehicles that are wrapped in specific heart, their heart wrapping. Again, we're very strategic not to make them look anything like law enforcement vehicles. And so I think now we're in a good place, and we're not having the issue with finding staff to fill the positions.
Larry, do you want to go ahead?
Okay. It's also important in your leadership that the first person you have that's doing this is their response to community and people is yes. We always find a way around no. We find a way around yes. And how do we provide the service? And once your staff sees that you're about yes and not about no, then you can start collecting. Because once you become a bureaucracy, and once you become, oh, we don't do that after 5, we don't do this, we don't do that, your program is dead. And I've been a part of programs that are dead, that had mobile crisis response, but they're like, at 3:30, we don't respond at 3:35. Sorry, boom. Then your officers won't call back. So if you're talking about officers, you got to do it right the first time. Otherwise, they're like, we're out. I got my skills. So you got to have that yes person, and that starts to build your staff right there. Thanks.
Yeah, and I'll just close out in saying that, this is across the board. I think this is where there's another opportunity to really get policymakers to sit up and pay attention. Is there is not a law enforcement agency in this country that is not having a problem staffing up. People do not want these jobs. There is not a 911 call center that does not have staffing problems right now. This is across the board challenges people are having. And so I think it creates an opportunity to really think about what kind of employees do we need, right? Who do we need to respond to this? Because on top of that, we need 6,500 mental health providers in this country in order to fill the gap, the need gap that exists. So I realize that I'm offering a very bleak outlook, but I'm also trying to offer you this opportunity, that this is an opportunity to start exploring what do we need. So NAMI has been really, we've been supporting the work of some researchers, Dr. Amy Watson, who's with Michigan State University, Dr. Leah Pope and Dr. Michael Compton, who are both with Columbia University in New York City. We've been supporting some work that they've been doing to try to break down what are the core competencies of someone who might be a crisis response professional, and how do we make sure that it doesn't require you to have, like, do we actually need someone with a 4-year degree and a master's degree and a PhD? All of these things that create really high barriers to entry for a lot of people, especially when we're talking about trying to reach into marginalized communities, communities of color, American Indian, Alaskan Native, a lot of these communities that we're really trying to reach. The traditional mental health service providers are not going to cut it. And so it's an opportunity to really look at how do we train a new workforce that has the potential to respond to mental health crisis, look at what the needs are of folks, and try to serve their community and really do some of that in-reach that is needed, that really helps and builds trust, that then allows kind of that connection. Because I think the thread, if you hear through a lot of the comments that both Lupe and Larry and I will say less to myself because I am not in the field really doing the work right now, is that people were able to build trust and people were really able to connect to that person. And I think when we do that, we're really able to reach people that really need the services the most, and those who really do not trust the existing system as it stands. And so I'd say take this as an opportunity to really look at, what are you asking for? And what are the needs? Like, what do you actually need someone to do? And can you create, is there the ability in your community to create job descriptions around, what it is that you actually need the person to do, instead of saying like, oh, we just need a mental health professional, we just need a social worker. What do you actually need that person to do? And really critically think about this. And you guys, this group is not the only one thinking about that. I did a similar presentation to this at the National League of Cities annual conference. We talked all about workforce. So, leaders in every community are thinking about this. And so this is a really excellent opportunity to really push on what is the different workforce that we want to see in our communities. And I'll just leave it at that.
And I'll just yell peer support, because you're getting those folks who have been affected, who would be part of this population, but now they've joined that peer support, and basically they're talking to their friends, right? And they're showing their friends there's a different way to live, that you don't have to hustle anymore. You don't have to do all these things. And this is a credible source of income that then can provide the basis to then lead on to other paths. Either they stay in the field professional, or they go off the path and they do something else with their life. So, and we need to make sure that our peer support folks are paid more wages than they could make it going to McDonald's, and to really make this a step, the stepping stone that people need, because we need their lived experience, because they have a lot of credibility when they go in community and say, you could do something different. Here's the pathway. I did it, and I was exactly where you are at. That is an incredible message. Thanks.
And thank you so much to all of our panelists. Again, if your question did not get answered, or you just want to chat, or you want to get in touch with one of the panelists, please feel free to send me an email. And we will have a recording of this webinar. It will be sent around after this, along with our report that we've been referencing. So we also have a survey. If you could please complete the survey, that would be wonderful, so we can improve future webinars. And finally, if any of the panelists have something that they want to highlight right now, I don't think that they do. I think we put stuff in the chat, but give them one last chance. Okay. Thank you. Oh, go ahead, Larry.
I've never met you before, and I'm a person that loves the playground, because at the playground, what's the best thing? That you can meet a person and have a good time. Their name isn't important, because I don't know your name. But what I do know is you're a part of this. And because you're a part of this, you care about people and you love people and you want people to have good lives. So I appreciate you and thank you for coming on.
Thanks, everyone. Have a good day.